Today is a special day. Today B. Braun takes part in the process of a couple becoming a family. Today a baby becomes a part of our society. Today we present not only products, but therapies and insights. Today you will be part of the miracle of birth. After patient admission, the woman is admitted to the obstetrics ward. But wait, why not go directly to the delivery room? It's time, isn't it? Wait, wasn't it explained in the B. Braun obstetric compendium that it takes a few more hours until the cervix is fully dilated, and only then would she change the ward? As a part of the birthing process, there are several checks and medical briefings that ensure related risks are reduced to a minimum and complications are avoided. The cardiotocography, or the electronic fetal monitor, is placed to record the fetal heartbeat and the uterine contractions. Due to the B. Braun compendium, the baby's heart rate is anywhere between 110 and 160 beats per minute and increases when the baby moves. The baby's heartbeat rate is just fine, as are all other examination results. In a nutshell, the pre-check looks great. As a part of the compulsory medical checks in the last weeks, there was a discussion regarding supportive techniques against pain during delivery. The woman has attended several prenatal classes and would like to have a baby without any additional medical support, like an epidural anesthesia. Pain is subjective. The woman now feels that she is not able to manage the pain and is asking for support, but for her, it is vital that she has a natural birth. Based on new evidence, as also summarized in the B. Braun Obstetrics Compendium, modern analgesia concepts do not increase the incidence of C-sections. It has also been proven that the mobilization, like walking, is good for the mother and the child. Modern concepts reduce pain without any negative side effects on the ability to walk. One technique which could be performed to combine best of both worlds, less pain and mobilization, is walking PDA by using a pump, either an elastomeric or an electronical. The couple is walking around the hospital waiting area to keep the mother occupied while they wait for the upcoming delivery. Suddenly, though, something changes. The woman is convinced that there is something wrong with the baby. Now, they are performing another CTG. This is done mainly to calm the woman down, since everything was already checked and found to be in order a few hours earlier. However, everything is not in order. The CTG seems incorrect. It is slower than it should be. The movement of the baby has reduced, and the ultrasound is not showing a clear picture. A natural birth is no more in the picture. This situation could be life-threatening to both the mother and the child. An emergency C-section would have to be conducted, without knowing if at the end the life of the child could be saved. The surgeons have performed an extraordinary job. After spending 2 nights at the hospital, the mother can be sent home with her last pain medication in the early morning from the night shift nurse. The wound is healing and the baby is fine. In a hospital environment, there are always risks, especially when the risks are not recognized by everyone involved. But why does this happen? If we analyze the risks, we would understand where they come from. Right now, the same syringe with a lure connector can be connected to several devices and patient accesses. Consequently, it is possible to connect the syringe containing local anesthetics with an IV access. This could be life-threatening. And FIT is a dedicated non-lure adapter for all products which are used in regional anesthesia. Here, the nurse will recognize there is a mistake, since she won't be able to connect the syringe with the IV access. Finally, after all the ups and downs, this family is on their way home. They will go on with their lives and maybe even forget this incident, but if there's one thing it shows us, it is that risks exist. And if they are known, they can be avoided. And we can help.
These kind of cases can be picked up from many different angles. I mean, the portfolio, which is kind of the forefront here, is all around the anorexia portfolio with some innovations coming, but this portfolio stands for more than 120 million euros globally with a group profit margin of more than 45%.
John Smith, age 55, height and weight 1.85 meters, 90 kilogram. Existing conditions? None. Allergies? None in patient history. Diagnosis? Tear to the anterior cruciate ligament of the right knee. Selected procedure: anterior cruciate ligament reconstructive surgery. Type of surgery: laparoscopic. In this case, I have 2 possible options for anesthesia that I can present to the patient: TIVA and spinal anesthesia. Spinal anesthesia would mean improved cardiac pulmonary function while eliminating the use of opioids, thus reducing nausea and accelerating recovery. Now that we have two new short-acting spinal drugs, prilocaine and chloroprocaine, the time to discharge could be reduced to 2 to 3 hours, as opposed to using bupivacaine, which would take over 5 hours. The second option, total intravenous anesthesia, would mean faster onset of anesthesia and more control of anesthesia depth. Also, some patients tend to prefer sedation during complex operations. For postoperative analgesia, I will use a continuous peripheral nerve block. There is evidence that it can be a more efficient analgesia method in case of complex outpatient knee surgery in comparison to oral and IV analgesia. It will also allow the patient faster recovery by enabling him to start earlier with a knee mobilization and physiotherapy. Good afternoon, Mr. Smith. My name is Dr. Haskins, and I will be your anesthesiologist today.
Hello, doctor.
I see from your patient file that you had a ski accident resulting in serious injury of anterior cruciate ligament of your right knee. Is that correct?
Yes.
As your surgeon already informed you, he will perform a reconstructive anterior cruciate ligament surgery on your knee today. Depending on your preferences, we have two options for anesthesia, which each one have their pros and cons. First option is a regional or spinal anesthesia, which would anesthetize you from hip down. With this method, you have the advantage of faster recovery, better cardiac and pulmonary function, and less postoperative nausea. Spinal anesthesia implies that you would be pain-free but awake during the whole procedure. The second option is total intravenous anesthesia, or ATIVA, where you would be sedated through the whole operation. Here, you would also be pain-free, but may have to deal with some postoperative nausea. Knowing that anterior cruciate ligament reconstruction is painful, and to keep you pain-free after the operation, we recommend the placement of a peripheral nerve block catheter for postoperative analgesia. Catheter-based analgesia will ensure that you experience significantly reduced pain after surgery. At the same time, it will speed up your recovery and discharge by allowing you to mobilize your knee and start physiotherapy as early as possible.
Dr. Haskins, if I understand you correctly, spinal anesthesia would still leave me conscious and aware of the whole course of the surgery. Is that right?
Yes, that is correct.
Oh, well, I have to say that I definitely don't want to be awake during the operation. I understand the benefits of spinal anesthesia, but I still prefer to sleep. For the post-operative pain, I will follow your advice. I prefer to have the catheter if it means I can get on my feet earlier.
All right then. As a first step, I will put in the catheter and then wheel you into the operating room for total intravenous anesthesia. Nurse, can you please prepare the ProSet and the ultrasound? Efficient processes are the cornerstone of successful surgery. The ProSet for peripheral nerve block is a complete procedure kit encompassing all the items required by the anesthesiologist, such as the ultrasound probe cover, patient drape and needle, all wrapped up in a sterile field shield. Using ProSet helps reduce risks, while also reducing the time taken by the whole procedure. Using ProSets also helps hospitals standardize their processes without impacting their costs. Ultrasound is a basic tool to facilitate all types of regional anesthesia. It is proven that ultrasound leads to higher success rates, less complications, and increased efficacy. B. Braun's Experius is the new innovative point-of-care ultrasound system that is designed to improve regional anesthesia procedures significantly, boosting procedural efficiency. Experius offers a high degree of mobility and flexibility combined with ergonomic design that improves daily practice. A fully articulating arm allows easy adjustments of the ultrasound monitor position and the angle of the screen for ergonomic use and enhanced use. It offers the opportunity to bring the screen and touch controls at arm's length to operate the system by oneself. With 4 transducer holders, accessory bins, basket and a work desk, you can easily access everything you need during the procedure. Experius provides clear and crisp images of nerves and tissue structures for accurate diagnosis and precise needle-guided procedures. With less need to adjust controls, you can focus on the procedure and your patient. Its simple interface workflow supports daily routines and provides specific presets for procedures in regional anesthesia and vascular access, ensuring confidence that you have excellent image quality and therefore the best conditions for a successful block. Product highlights. Contiplex Ultra 360 is a continuous technique needle designed to perform ultrasound-guided peripheral nerve blocks in combination with nerve stimulation. The high-quality coating enables smooth gliding through tissue and easy handling. The special X pattern, with an increased number of reflecting corners, ensures high ultrasound beam reflection, enabling easy visualization of the needle tip and needle shaft with very few artifacts. Safety code short long allows easy recognition of the exact needle part that is being visualized. After the catheter is placed, the patient is wheeled into the operating room, where total intravenous anesthesia can begin. Total intravenous anesthesia is induced with a bolus injection and then controlled via target-controlled infusion. After surgery, the patient is transferred to post-anesthesia care unit and then to the ward. In the meantime, Mr. Smith has been transferred to the ward where the discharge process will begin.
We have selected an elastomeric infusion pump to manage your pain during recovery and physiotherapy. This pump delivers a continuous infusion of the pain medication at a controllable flow rate, so we can mobilize you while significantly reducing your pain. The pump shrinks in size, becomes lighter, more comfortable to wear and carry, allowing you to move around.
Mr. Smith can benefit from rapid mobilization and can be expected to be discharged from the hospital within the next 2 days.